Welcome, everyone. We're very glad you were able to join us this evening. I'm Debbie Day. I'm a board member for the San Diego American Heart Association. My day job is the Executive Vice President and General Manager at Mitchell and Light Company. That's a software company based here in San Diego. I'm truly excited to have you all join us today for this engaging panel discussion on something we believe deeply in at the AHA, and I know Sharp Healthcare does too: women's heart health before, during, and after pregnancy. Caring for women and birthing parents in their reproductive years while ensuring maternal health is equitable across populations begins long before pregnancy and lasts well before childbirth. So it is my great pleasure to introduce you to our panelists for today's conversation. Dr. Marin Nishimura is a board-certified physician in cardiovascular disease and internal medicine. She practices with Svaro Cardiovascular Institute in El Cajon and is affiliated with Sharp Grossmont Hospital. Dr. Nishimura completed medical school at the University of California, Davis, and did her internship, residency, and fellowship at the University of California, San Diego. Dr. Lisa Johnston is a board-certified physician in obstetrics and gynecology and serves as the co-chief medical officer at Sharp Mary Birch Hospital for Women and Newborns. She has been practicing for over 20 years, working with women from adolescence through menopause to provide a continuum of patient-centered care. Dr. Johnston completed medical school at the University of Western Ontario and did her internship and residency at the University of Toronto and St. Joseph Mercy Health System, respectively. So I want to take a minute to highlight the mission of the American Heart Association, and as well as its research, and that will demonstrate the cruciality of today's topic. The American Heart Association, lovingly referred to as the AHA, has a mission to be a relentless force for a world of longer, healthier lives. We are working with experts and volunteers across the globe to achieve this through a focus on the areas seen here on the left, always based on science, and with equity at the center, guiding all the work we do. More than 18 years ago, the AHA launched a Go Red for Women to bring awareness that heart disease is the #1 killer of women, and that women are often misdiagnosed and unaware of the lifestyle changes they can make to help prevent heart disease. We have made great strides in raising awareness, educating women, and providing programs and resources to those who need it most. But we must continue to do more as heart disease continues to claim the lives of women. That's why we are so grateful for those who come alongside us, like Sharp Healthcare, and supporting the conversation as we work to break down barriers to health equity right here in San Diego. So we're going to look at 3 primary topics today: an overview of women's heart health, the pregnancy-related cardiovascular conditions, and addressing cardiovascular conditions after giving birth. So let's take a look at each one of those. Cardiovascular disease continues to be the #1 killer of women, claiming more lives than all forms of cancer combined. The reality is nearly 45% of women over the age of 20 are living with some form of CVD, and women are also experiencing unique life stages that put them at increased risk of developing CVD over the course of their lifetime. Pregnancy-related deaths in the US have risen 140% over the last 3 decades. CVD continues to be the leading cause. There are major racial disparities existing in maternal health outcomes. Black women experience pregnancy-related death at a rate 2.5 times higher than white women and 3.5 times higher than Hispanic women. The American Indian Alaska Native women experience pregnancy-related death more than twice as often as white women. Cardiovascular disease during pregnancy leaves women with a higher lifetime risk of CVD after delivery and increased risk for their children. Almost 2/3 of cardiovascular conditions can be prevented. Preventative care and early intervention are critical during pregnancy and postpartum. From adolescence to adulthood, life is measured by ages, stages, and seasons. The transition into early adulthood, motherhood for many, to the struggle to keep up while nature slowly decreases our physical ability to do so. As the milestones of a woman's life change, so do her unique risks for developing cardiovascular disease. So there are 4 key risk factors. You can see them here: age, race and ethnicity, high blood pressure, also known as hypertension, and weight. Let's look at those. Women 35 and older are at higher risk of pregnancy complications and pregnancy-related deaths. Risk of pregnancy-related death in women 40 plus is nearly 8 times higher, 81.9%, than of women 25 and younger, 10.6. Race and ethnic disparities in pregnant-related mortality are significant, peaking among Black women. Mortality rate differences are significant, 42.8% among Black women, 32.5% among American Indian, Alaskan Native, 14.2% among Asian Pacific Islander women, 13% among white women, and 11.4% among Hispanic women. Difference in the quality of pregnancy care and in outcomes have been linked to factors such as race, ethnicity, geography, and income. Systems in place that promote racial inequities can limit access to care and amplify pregnancy risks. And then our other 2 risk factors, high blood pressure, aka hypertension, is on the rise. Rates of chronic hypertension, having high blood pressure even before pregnancy, have also increased. The dangers, hypertensive disorders in pregnancy include preeclampsia and eclampsia, and can make it harder for a fetus to get enough oxygen and nutrients to grow, increasing the risk of an early delivery. It's important also to maintain a healthy weight throughout life, but especially before, during, and after a pregnancy. Obesity is a major risk factor and could account for nearly 1/3 of a steep increase in U.S. pregnancy-related deaths. Obesity before pregnancy, from 2011 to 2015, pre-pregnancy obesity increased 8%, with the most severe obesity increasing 14%. Maternal mortality increases with BMI. Pregnant women with a BMI at above 30 face 3.7 times the risk of pregnancy-related death than other women. Pregnancy and childbirth can put women's health risk at risk, but many pregnancy-associated deaths can be avoided. Women should be aware of their risk factors, manage their medical conditions before pregnancy, and always communicate their concerns with their healthcare team. So that is our opening. That rounds out our introductory remarks. Please join me in welcoming Dr. Marin Nishimura. Welcome, Doctor.
Thank you for the introduction. Hello, everyone. Good evening. My name is Dr. Marin Nishimura. I'm a general cardiologist at Sharp Grossmont Hospital. I have a special interest in women's cardiovascular health, with particular passion with heart health issues during pregnancy, and of course, in the postpartum period as well. So at Sharp Healthcare, our mission is to improve the health of those we serve with a commitment to excellence in all that we do. Our goal is to offer quality care and services to set community standards, exceed patients' expectations, and are provided in a caring, convenient, cost-effective, and accessible manner. And in order to do that, Sharp makes it very easy to get the care you need very close to home. So throughout San Diego, there are 4 acute care hospitals: Sharp Grossmont Hospital, Sharp Memorial Hospital, there's Sharp Coronado, and Sharp Chula Vista. There are also specialty hospitals such as the Mary Birch Hospital, and also a full spectrum of other facilities and special services. For example, pictured here is our very new postpartum hypertension clinic, which just opened late last year, and it is located at Sharp Grossmont Hospital. And it is actually first of its kind in San Diego. It is a multidisciplinary clinic with collaboration between obstetricians and cardiologists to take care of women who had hypertensive disorders during pregnancy and after delivery. Next slide, please.
Okay, we're going to open up with our first polling question. Thank you, Doctor. We're going to hear a little bit more from you in a minute. Please join us in answering this poll question. And as quickly as possible, we're not going to keep it open too long. Which of the following is not, that's key, a cardiovascular risk factor? Just take one choice. You can either say high blood pressure is not, obesity is not, low cholesterol is not, or age is not. Hopefully, if you listen to the opening remarks, you have a pretty good appreciation for which of the following is not a cardiovascular risk factor. Please just take a second, hit submit, and then we'll look at the results in just a second. Very good. Low cholesterol is exactly the answer. Age is a cardiovascular risk factor, but very, very good job on the polling questions. And back to you, Doctor.
Okay, so why is heart disease in women so important? So as you know, or as we discussed already, cardiovascular disease is the leading cause of death worldwide. And although heart disease is sometimes considered more of a men's disease, it actually affects both genders equally, and they are affected equally by cardiovascular disease. And in fact, cardiovascular disease is the leading cause of death among women in the United States, as discussed. All right, and here are some statistics to put this fact into perspective. So overall, 1 in 3 women die from cardiovascular disease. And cardiovascular disease kills approximately the same number of women as all forms of cancer, chronic lung disease, and diabetes combined. And in 2014, 1 in 32 female deaths was from breast cancer, whereas 1 in 3 was from cardiovascular disease. An important thing to know about heart disease is that not only is it the #1 killer of women, but it is also a largely preventable disease process. So nearly 80% of the heart disease could be prevented with better lifestyle choices, such as not smoking, participating in regular exercise, and eating a healthy diet. So who is at risk for heart disease? Those individuals have personal history of coronary disease, stroke, also family history of early coronary disease, particularly under age of 55, history of high blood pressure on medications, high cholesterol, diabetes, obesity, chronic kidney disease, and also smoking. And there are also cardiovascular risk factors that are specific to women, such as the timing of menarche. So either early or late menarche could increase your risk, as well as early menopause, whether it was by hormones or by surgical procedures, diagnosis of polycystic ovarian syndrome, autoimmune diseases such as lupus, which is more common in women, a history of breast cancer, and also the treatment that you have received, whether radiation or chemotherapy, and hormone therapy use. But today in our, what we're going to focus on today is going to be the pregnancy associated risk factors that can lead to complications during and after pregnancy.
So thank you so much, Dr. Nishimura. We're going to hear from you as we conclude. And, if people have questions, you can put them in the Q&A box. But we now would like to welcome Dr. Lisa Johnston. Welcome, Doctor.
Thank you, and thank you for having me. As Debbie mentioned at the beginning, my name is Dr. Lisa Johnston. I'm a OBGYN who works for Sharpry Staley Medical Group. And I have been working with Sharpry Staley since 2008, but I've been in practice since 1999. And as she mentioned, I'm originally Canadian, so I did my training and my residency, et cetera, up in Canada. So, but then I moved to the sunny South and live here in San Diego and love it. So I'm happy to be here, and I commend all of you for attending this and trying to sort of learn things that you can do to keep your heart healthy and have your pregnancy move along smoother and sort of avoid some of these obstacles that may affect your future heart health in the future. Next slide.
Okay, our second polling question. This one is pretty straightforward also. Only you can just say true or false here. Nearly 75% of cardiovascular diseases can be prevented through better lifestyle choices. So just take a second, true or false. Hopefully that's becoming clearer as we move through tonight's presentation. Please take a second, hit true or false, hit submit, and we'll look at the results. Yay, fantastic.
Everyone got it right who answered. Good job. Good job.
Very nice. Very nice. Back to you, Doctor.
Thanks. So along those lines, I mean, what can you do to try to keep your heart healthy and have your pregnancy go well? Pregnancy is an important factor when it comes to heart disease, and sometimes finding out about heart disease that you may not know about, or risk factors that exist without being pregnant that you would never know about. Because pregnancy results in multiple changes to a woman's body and can be likened to a cardiac stress test for the mother. Several pregnancy complications, such as preeclampsia and gestational diabetes, are considered independent risk factors for future heart disease. An abnormality during pregnancy can mean an early indicator of later cardiac disease. Adverse pregnancy outcomes occur in approximately 10 to 20% of pregnancies and are associated with a 2 to 4-fold risk factor of future cardiovascular disease. Next slide. Some of these complications during pregnancy include hypertensive disorders of pregnancy. And that's sort of a big group that can be subclassified into preeclampsia, which is essentially hypertension and sort of some associated symptoms such as protein in your urine, elevated liver enzymes, platelet abnormalities, which are sort of blood abnormalities reflecting liver dysfunction and kidney dysfunction. Gestational hypertension, which is just hypertension alone associated with pregnancy. And then chronic hypertension, which essentially is hypertension that exists prior to pregnancy. So some women come into pregnancy already having the diagnosis of hypertension and may even be on medication to control their hypertension when they get pregnant. Those women also have a higher risk of associated preeclampsia. So you can have sort of pre-existing hypertension and then develop preeclampsia during your pregnancy. And then there's gestational diabetes, which is essentially just diabetes associated with pregnancy. So why does pregnancy sometimes cause hypertension or, essentially preeclampsia and things that cause complications during your pregnancy? Well, a lot of it has to do with the physiology of pregnancy and a lot of the changes in your maternal system that allow us to grow and carry a fetus inside our uterus. Pregnancy acts as a natural stress test for the heart. And in fact, during pregnancy, your blood volume is increased almost double. So it's almost increased by 50%, which causes increased blood flow. And this increased blood flow allows a baby to grow. So you increase your blood flow to your uterus through an increased blood volume. But because our blood volume when you're pregnant is so much higher, this causes a lot of extra cardiac workload and stress to the heart. And these things may cause temporary spikes in blood pressure and may change your blood glucose. So women who are not diabetic outside of pregnancy because of the placenta and factors sort of released by the placenta, you may develop diabetes during your pregnancy. And then obviously labor and delivery, when you're trying to push out a baby for hours on end, hopefully shorter than that, but sometimes for a long time, also is like an exercise stress test and may add to your heart's workload. Next slide. So what is preeclampsia? I've mentioned it a few times. Essentially, preeclampsia is high blood pressure or hypertension that can occur during pregnancy. Preeclampsia diagnosis approximately doubles a woman's risk for heart disease and stroke over the next 5 to 15 years. And quite honestly, there's been a lot of research in this area that has come out and is really important in the last 10 years. When I first started practice, it was sort of thought that preeclampsia was just related to pregnancy and really didn't necessarily increase your risk for hypertension or heart disease later on. But we really do have great data to support that it really does. And so doing what you can to be healthy before pregnancy and during pregnancy is going to have wonderful long-lasting effects throughout your life. So risk factors for preeclampsia, well, there's certain things you can do things about, and there's certain things that you can't. And the fact that you're here listening to this means that these things matter to you. And so we're going to try to sort of go through things that obviously increase your risk, but things that you can change or do in your life to decrease your risk for preeclampsia. So preeclampsia in a previous pregnancy obviously increases your risk. Being pregnant with more than one baby, so twins, triplets, etc. Pre-existing hypertension or chronic hypertension prior to pregnancy will increase your risk for preeclampsia. Type 1 or 2 diabetes before pregnancy. Autoimmune disorders such as lupus that was mentioned earlier. Pre-existing kidney disease and or obesity. Of all of these things, there are a few things that you can do things about, one of them being your weight and another being trying to decrease your risks for hypertension prior to pregnancy. And as far as diabetes go, if you control your sugars well before pregnancy, that also has great impact when it comes to developing these complications during pregnancy. Next slide. So preeclampsia can develop a lot of complications during pregnancy, and they can involve both the baby and the maternal systems. Because preeclampsia generally is high blood pressure, it will cause sort of constriction or narrowing through the vessels of the placenta. And through this, it will cause decreased fetal growth. So sometimes babies can be growth restricted due to chronic hypertension that isn't well controlled and or preeclampsia. Because of these changes in the placenta, often if women's blood pressures are very high, we will have to deliver the baby early. And so that increases the risk of preterm birth. Placental abruption is when there is bleeding behind the placenta that puts the baby at risk and also puts the mom at risk. And this can be caused because of high blood pressure, causing the placenta to separate and bleeding to exist behind it. And this can be a huge obstetrical emergency. Eclampsia is a seizure, and this is something that can happen when you have preeclampsia, especially in the setting that your blood pressures are not well controlled. So we will use medications to control blood pressures, and I'm going to talk about that a little bit. But if your blood pressures are poorly controlled or spike up very high, then there is an increased risk of seizure, which is called eclampsia. It can also damage your liver and your kidneys, and obviously can cause both short-term and long-term cardiovascular disease. Next slide. So the treatment for preeclampsia, essentially I alluded to it before, that delivering the baby is the ultimate treatment for preeclampsia, and managing the condition until the best time to deliver the baby. So if you develop preeclampsia relatively early, then we often will try to delay your delivery until the baby is more mature. But sometimes things get very severe and blood pressures are hard to control, and this puts your baby at risk for things that I had mentioned before, such as growth restriction and abruption, and causes us to deliver the baby early. We can monitor your blood pressure, and obviously we do that in the office. And sometimes for women who have pre-existing hypertension, we will often recommend that they monitor their blood pressures at home and get a blood pressure cuff and report any blood pressure abnormalities to your physician, or any change of symptoms, which we will talk about in a few slides as far as symptoms associated with preeclampsia. Or if you are concerned at all about the health of your baby, obviously you have to bring that up with your provider. For severe preeclampsia, so this is generally when blood pressures are fairly high. Often we use the range of greater than 160 over about 100 or 110, which are the systolic and diastolic blood pressures respectively. You will be hospitalized for management. And some of the management would include drugs to lower your blood pressure and try to get it into the normal range. We often will use anticonvulsant medications, and in particular magnesium sulfate, to prevent seizures through an intravenous drip. And then we will also give you corticosteroids, and those corticosteroids are to help mature the baby's lungs and help protect the baby's brain and GI tract should we need to deliver the baby early because of the preeclampsia. Preeclampsia does tend to get worse as you go through pregnancy, and so that's why doing whatever we can pre-conception and also during pregnancy to try to prevent it is obviously in your best interest. Next slide. So we'll change gears a little bit and talk a little bit about gestational diabetes. As mentioned, this is diabetes that develops during pregnancy in women who don't already have diabetes. This often develops around the 24th week of pregnancy, but this is also when we screen patients for it. We do tend to screen some women earlier during the first trimester if they have a history of gestational diabetes, or if they are particularly obese with a high BMI, or have strong family history of diabetes, et cetera. But for most pregnant women, we will screen you between 24 to 28 weeks. And we do screen all pregnant women because it's something that often is asymptomatic and that we really don't know who will and will not develop gestational diabetes. The development of diabetes at any age increases the likelihood of future heart disease and high blood pressure during pregnancy. It heightens your risk for diabetes later on in life by 50%. And your baby will also be at higher risk for things such as being very large, which we call macrosomia, which can make delivery more difficult, being born early, which can cause breathing problems and other problems, obviously, that are associated with prematurity. Babies can develop low blood sugar when they are born because of sort of chronic exposure to high blood sugars in your system. This will cause the baby's sugars to drop low when they're born. And so just they will have a higher incidence of having to go to the neonatal intensive care because of that. And then also, if you have diabetes during pregnancy, your child is at an increased risk of developing type 2 diabetes later on in life. Next slide. So how do we lower people's risk for gestational diabetes? Well, preconception, so prior to pregnancy, controlling your body weight and losing weight if you are overweight or if your BMI is high is very, very important. And, you know, all pregnant women obviously gain weight during a pregnancy, and this is important to grow your baby. And this is something to not stress about, but something to try to control. And, you know, in controlling those, we will talk to you a little bit about diet and exercise. So controlling your weight or getting back to your pre-pregnancy weight a year after delivery prior to embarking on your journey for your next baby is also really important. And you should have your hemoglobin A1C and your blood sugar, which are both tests to try to screen for diabetes, tested prior to pregnancy and certainly tested during pregnancy if you have risk factors, or as I mentioned, between 24 to 28 weeks. How do we treat gestational diabetes? Well, we check blood sugars quite frequently, usually about 4 times a day. We check fastings in the morning prior to eating, and then we usually check them an hour after you've eaten. We do recommend specific gestational diabetes diets, and you usually will meet with a dietitian and have a comprehensive diet plan, which essentially means eating healthier foods and watching your carbohydrate intake. You definitely should be active. And I talk to all my patients about the importance of exercise during pregnancy, sort of pre-pregnancy and during pregnancy especially. A lot of pregnant women are somewhat fearful of exercise, but exercise has actually been shown to benefit the baby and obviously benefit you when it comes to both your cardiac risk factors and gestational diabetes risk factors. So staying active during pregnancy is really a really important thing and does not increase your risk of preterm delivery, sort of contrary to what some people believe. And then obviously monitoring your baby as far as movement or any concern you may have about your baby is an important part of caring for gestational diabetic patients. And often if you are on medications to control your gestational diabetes, such as insulin, we will do more comprehensive monitoring near the end of your pregnancy, having you come in twice a week and doing things such as non-stress tests, which is monitoring the baby's heart rate to make sure that the baby looks healthy. Once the placenta is delivered, because as I mentioned earlier, placenta has a lot to do with gestational diabetes, and the hormones that the placenta makes will cause often women who sort of have underlying risk factors to develop diabetes. Once the placenta is born, usually your blood sugars will go back to normal, but that doesn't change your risk factors moving forward in life. So that's an important thing to remember. Next slide. So what can you do to help your heart? Well, you can make sure your primary care doctor knows if you have had any of these pregnancy complications. And this is really important because, you know, in healthcare, obviously as obstetrician gynecologists, we're used to taking care of you during your pregnancy, but I'm not sure that all that information always gets to your primary care doctor. So it is important to bring these things up with your primary care doctor so that they can be well aware and they can help guide you through the rest of your life when you're not pregnant and help you decrease these risk factors. You need to know your risk for heart disease now and as you age. So particularly your weight, your family history, and things that and your diet, things that we mentioned earlier. Moms should practice healthy habits before, during, and after pregnancy, such as being physically active, eating a healthy and balanced dietary pattern, stop smoking and or vaping, and certainly avoiding secondhand smoke is important. Managing your stress, easier said than done, but it is really, really important. Making sure that you get enough sleep, monitoring your weight gain, and monitoring your mental well-being. Trying to lose weight gain during pregnancy within the first 12 months. So I sort of mentioned this earlier, that trying to get back to your pre-pregnancy weight by about a year after delivery would be an important goal. No, not 6 weeks. A lot of postpartum moms come in at 6 weeks and are upset that they haven't lost all their weight. And that really is standard. I think only in Hollywood did they lose all their weight by 6 weeks. So it's really important to know that this is sort of a year-long process and to not be let down with yourself if you haven't lost all your weight by 6 weeks. Next slide. How to maintain heart health after pregnancy. These are the things that we talk to patients about who have preeclampsia or who have chronic hypertension during pregnancy. Once you've delivered, we talked about, you know, that is the sort of cure or the treatment for preeclampsia. However, often these things don't go right away. And so this comes down to that postpartum period when actually this is the highest risk for having a seizure or highest risk of having eclampsia. You need to be on the lookout for these following things. Headaches are really important. If you have severe headaches, that is one of sort of the harbingers or one of the clues that you could be at risk for very high blood pressure and seizure. So pay attention if you have headaches that aren't relieved by Tylenol or rest. If you have vision changes, so sometimes pregnant women will see little floaters, and those are really common and those aren't of concern. But if you start to get blurred vision and or see big black spots called scotomata, those are important things to bring up with your provider. If you start having chest pain, obviously that's of concern and you need to let your physician know. Palpitations are another thing that we do see commonly during pregnancy. However, if you start to feel a lot of extra beats, or if you start to get short of breath with your palpitations, or if you get chest pain associated with your palpitations, that would be sort of more than just the average skip beat, et cetera. And that would be something to bring up with your physician. Most women, as I mentioned, who either have chronic high blood pressure or chronic hypertension prior to pregnancy or preeclampsia during pregnancy will be asked to monitor their blood pressure when they go home from the hospital. And the goal is to try to keep their blood pressures less than 140/90. And that would usually involve medications that people are treated with in the hospital and sent home with. We can often wean people off those medications, but they usually do, they often do, especially if your blood pressures were severely abnormal during pregnancy, you often will have to go home on blood pressure medication. And with time, we can often get people off of those, often by 6 weeks, but some people have to stay on them longer than that. Shortness of breath, obviously, if you're feeling like you can't breathe or catch your breath, especially after you've had your baby, it's really important. A lot of pregnant women will feel just sort of a baseline shortness of breath, or sometimes even have difficulties talking in full sentences. Like I joke with my patients that when I was pregnant, I had a hard time doing my job because I was constantly taking deep breaths. So that is normal, but if you're feeling that it's a lot worse, or if you're having a hard time breathing, especially after delivery, that would be really important to be seen and talk to your physician. And specifically difficulty when you're lying flat, difficulty breathing when you're lying flat. Again, when you're pregnant, sometimes it'll be a little hard just because you have babies pressing up on your lungs, et cetera. But if you're really feeling breathless when you're lying flat in bed, or especially after delivery, that's can be a sign of underlying cardiac disease. Leg swelling is another thing that a lot of pregnant women get, and can get worse before it gets better, especially after delivery. So often we will see increased leg swelling. However, if you're having certainly unilateral or one-sided leg swelling, that's an important thing and can be a sign of a blood clot. Or if you have leg swelling in association with underlying hypertension or high blood pressure, or just really significant leg swelling that is sort of more than just what you had during pregnancy, it would be important to talk to your provider about that. Next slide. So obviously, your cardiac health is of the utmost important, and we did talk about stress management being important. So sort of leading towards, your overall fitness and overall health, heart and mental health sort of somewhat go together. So I'm just going to briefly talk about this, and we're going to provide some resources in the next slide. But essentially, if you're feeling down, if you're feeling depressed, if you're having a hard time with anxiety and stress, please talk to your provider about it. We're here to help, and we're here to sort of help connect you with community resources that are available out there for you. Try to rest as much as possible. Having a baby and growing a baby is an exhausting process, and you sort of need to lean on your community and lean on your family. It truly does take a village, and you as the mother can't do it all. So get your partner or your significant other or your family members to help you out and try to get some rest. Easier said than done, but it is really important. Obviously, as I just mentioned, ask for help from your partner, your family, your friends. Sometimes people don't necessarily know how to help. So please, you can be direct. People will help you if you just ask for it. And there's no shame in that. Like I said, we can't do it all alone. Make sure you're finding some time for me. I mean, you have this new baby, and much of your focus is going to be on your new baby, feeding your baby, recovering from delivery, and just trying to get some sleep. But it's okay to, take a few minutes and go for a walk around the block. Have your partner watch your baby for a little bit, and just trying to find time for you throughout the day is really, really important, and will help both your cardiovascular fitness and your mental health. Talk about how you're feeling. I mean, a lot of pregnant women and postpartum women feel extremely anxious, and also feel anxious about leaving their baby with their partner and their family and their friends. So talk to people about your anxieties and your fears, and they will be able to help you through. And also talk to your OBGYN and your physicians. And we'll talk a little bit more about this, but there are other support groups out there, the American Heart Association, and we talked earlier about the postpartum cardiovascular clinic that's sort of new in Sharp, that are all available for you. Next slide. All right, Debbie, take it away. I think that's my comprehensive pregnancy cardiovascular talk.
Awesome. What a jam-packed 40 minutes we've had so far. We've got 4 things to complete, gang. First of all, the resources that you see here, the maternal health infographic, the risk factors in pregnancy, the common heart conditions in pregnancy, and the support network forums, all will be emailed to you. So you'll be able to have access to that following the call. We're going to transition to, we have 3 questions submitted. We've got a little recognition for 2 of you that are joining us, and then we'll do the close. So let's do the questions. The first one was submitted ahead of time, and I think we're going to start with Dr. Nishimura, which is, aside from prenatal vitamins, and what other supplements do I need to ensure to incorporate into my diet?
Okay, thank you for the question. Aside from prenatal vitamins, but I think that is the most important one out of all the vitamins, most importantly being the folic acid that, prevents neural tube defects. Other than that, making sure that you still have healthy diet that's rich in fruits and vegetables, focusing on lean meats as opposed to red meats, and incorporating fish several times a week prior to pregnancy to make sure that you're at healthy weight, your blood pressure is controlled, your diabetes controlled, to prepare for healthy pregnancy and life beyond. So those are the tips.
Great. And Dr. Johnson, did you have something to add on that one?
Yeah, sure, absolutely. So we sort of assess at your first prenatal visit your risk factors for preeclampsia, and there are certain high risk conditions that I had mentioned earlier in my talk. And often these women, we will place them on a baby aspirin, so 81 milligrams of baby aspirin. is something that can help prevent or at least delay development of preeclampsia during pregnancy. So, you know, in the past, pregnant women have been fearful of aspirin, and you really shouldn't take regular dose aspirin, but baby dose or 81 milligrams of aspirin has been shown to be extremely safe and especially beneficial as far as preventing preeclampsia during pregnancy.
Great, great. And for the attendees, you can add your question into that Q&A box. There's a black ribbon at the bottom of your screen. And I'll read these next two because they're both really good. Is there anything different to consider for a first pregnancy versus a second for your heart health? And Dr. Johnson, I think this is over to you.
Sure, yeah. So nulliparity, or sort of first-time mothers, that's what we call first-time mothers, actually have a higher risk of preeclampsia. You know, it goes a little bit against the whole age thing. I think it has more to do with never being pregnant before and your body being exposed to the placenta and some of the placental factors that may increase blood pressures. So obviously you can't change that it's your first pregnancy, but what you can do is try to impact those modifiable risk factors that I mentioned prior to pregnancy. So controlling your weight, trying to lose weight if you have a high BMI prior to pregnancy is really crucial to decreasing your risk for diabetes and for preeclampsia. Eating a healthy diet, and we talked about, you know, incorporating fish. And I always talk to my patients about sort of the Mediterranean diet, which is essentially fresh fruits and vegetables, a lot of fish, lean meats, so, you know, lean poultry and stuff, and avoiding the red meat that we talked about. And lastly, exercise, making sure that you're exercising, at a minimum walking, but even, you know, more importantly would be getting some cardiovascular exercise and, you know, getting your heart rate up. And so I'll talk to patients about exercise before and during pregnancy, because those are the things that you can do to modify your risk factors and decrease your risk of preeclampsia and heart disease later on in life prior to your first pregnancy. With regards to differences between first and second pregnancy, essentially making sure that you try to lose that pregnancy weight by a year's time, and certainly prior to embarking upon your second pregnancy is really important, so that it's not sort of a cumulative weight gain throughout your life that you never really you know, get past, so it doesn't sort of keep piling on, so to speak. And again, you know, diet, exercise, getting enough sleep, minimizing your stress, all of those things will play into it, like trying to avoid that stress eating that happens.
Very good. Very good. Couple more questions. I know you mentioned 140/90, Dr. Johnson, but this question is, what is considered normal blood pressure these days? I've seen varying numbers.
Yeah, so I can comment on that. I think that pregnancy blood pressures and non-pregnancy blood pressures are very different. And you know, we can sort of talk a little bit about non-pregnancy, because I think sort of those standards are lowering a little bit, but in general in pregnancy, your blood pressures do go, they lower during the second trimester, and then they do tend to rise towards term. Essentially, normal blood pressures would be less than about 130/80 during pregnancy, especially near term. I wouldn't expect to see them quite that high second trimester. And we talk about changes over and above your baseline too during pregnancy. You know, if your systolic is going up a lot, like 30 over baseline, and your diastolic 15 over baseline, then those are sort of changes that we tend to monitor or be a little bit concerned about. But essentially that cutoff 140/90 tends to define preeclampsia within pregnancy, and it's on two separate occasions, you know, a few hours apart. So it's not just one blood pressure.
Good, great. And this one might be for both of you. Is there a higher risk of cardiovascular disease with prescribed bed rest?
I can talk a little bit about that. So first and foremost, in pregnancy, we are definitely getting away from bed rest. You know, we used to use it a lot, especially for preterm labor and stuff. It really hasn't been shown to be all that beneficial with regards to preterm labor reduction and preterm birth reduction. So, you know, yes, there are certain conditions where people will be hospitalized and will be on bed rest. Although, again, we really try to avoid strict bed rest unless unless rare circumstances. So that was my talk on bed rest. I forget, what was the rest of the question? What are
Is there a higher risk of cardiovascular disease with prescribed bed
associated
rest?
with bed rest?
Yeah.
I mean, not really. It's not, I mean, yes, exercise, and I did talk about the importance. If you're on bed rest, there's usually a really good reason for it. And I wouldn't worry so much about the negative impacts on your heart. It's more to try to help with your pregnancy and keep the baby in as long as possible.
Great. Anything to add, Dr. Nishimura, on that
no.
question? Okay, great. Okay, well, that completes our questions. I'd like to recognize 2 people who are attending that are going to get awarded a special little gift. And those 2 people are Anita Salvato and Joanna Hunt. So congratulations. They're going to the AHA will reach out to you via email. And this brings us to a close. So I'm just going to give a big thank you to our panelists. Thank you both, doctors. That was so great for joining us today, sharing your expertise and knowledge. Thank you for being leaders and voices in our community. I learned a lot today, and thank you for leading the way in patient and community wellness. I know everyone who joined us today is leaving feeling inspired with new ideas on how they can create healthier lifestyle choices, share the information they've learned today on women's cardiovascular health, even with your friends, family. You can expect shortly the recording of this conversation, and you can have the take-home resources will go into your email. On behalf of our panelists, thank you again for joining us today. Special thank you to our community conservation sponsor, Sharp Healthcare. Thank you all for joining us. All the best to you in your wellness. Thank you.
Thanks for having us, Debbie. And I just really want to congratulate Sharp for making this a priority, because it is really important. And I want to congratulate all the people who attended, because hopefully it will make a difference during your pregnancy and for your whole life to come. So thank you.
Awesome. Thanks, everybody.